All right, guys, I did bring candy today on break, so I'm not holding it hostage, just so you know if you need a little pick-me-up before I forget about it. Today we're going to be going over chapter 10, which is about respiration and artificial ventilation. If you guys don't feel like you have a good checklist kind of in your mind or flow when you eventually get to your practice of basic airway management, please go back through that, especially before tomorrow when Brandon goes over airway emergencies. So, in recap of yesterday, again, we're going to do our assessment, we're going to do our ABCs, then we're going to position the airway, add an airway adjunct like an OPA or NPA. We can go to a supraglottic airway, which is a blind insertion device because it does not enter the trachea, then ET tube, and then Craig. Obviously, you're not going to go straight always to an OPA. Sometimes it's going to be to an intubation, but never forget about the other tools that you have. Whenever you do put in any kind of airway adjunct, remember you're still going to be positioning that airway to help them as well. With traumas, it's hemorrhage ABCs. And really, guys, when in doubt, if you're a little bit lost in patient care, just keep going through your ABCs. They're called the ABCs for a reason and in that order for a reason. So for today, just out of your book, core competencies and concepts, we're going to be able to apply general knowledge of anatomy and physiology to the assessment to make sure that the airway is patent, that we can adequately mechanically ventilate someone and provide respirations for all ages. We're going to look at the physiology and pathophysiology of the respiratory system, how to recognize adequate versus inadequate breathing, the principles and techniques of positive pressure ventilation, or PPV, and the principles and techniques of oxygen administration. Oh, I lost my clicker. Sorry. Give you a clicker. Oh, okay. No wonder you guys don't know what I'm pointing at PPV on there. There we go. There's our competencies and concepts. When we talk about outcomes in general, we're going to be able to compare the physiology versus pathophysiology of breathing, the concepts of cardiopulmonary pathophysiology. So even though today we're primarily talking about oxygenation, ventilation, how we're able to manage that airway, your cardiovascular system is also extremely important in helping your lungs function correctly and how we provide care. We're going to be able to summarize respiration. We're going to be able to describe, again, assessment of patients' breathing, summarize concepts of positive pressure ventilation. We're going to be able to look at concepts related to administering supplemental oxygen, and then we're going to explain our roles and responsibilities related to the use of advanced airway devices. So some of the stuff that we've already talked about, like how oxygen is a drug and can hurt people, will get reiterated in this chapter because they're all important concepts, and each chapter kind of goes with one another. Sometimes the way the book is formed isn't always favorable for how you learn or how you tie these concepts in together. Most of my PowerPoints try to go in order of the book, so then that way if you've read it or if you go back through these PowerPoints through the lectures, it kind of goes with the book. But if you're like, I am lost here or there, and there's all these different concepts coming together, find the flow that works best for you guys. Any questions so far? Okay. So the book is a little bit different. It starts out with the basics kind of ventilation and respiration. So ventilation is essentially when air moves in and out of the chest, and that means it's a full breath in and a full breath out. Same like when you're counting your respiratory rate. Inhalation is an active process, so you have to actively and consciously, with your brain doing it, have to inhale to get air in. With how your lungs are made of compliance and the physical properties of your diaphragm, when you exhale, your body doesn't really have to do any work of it. A lot of times we get the synonym of blowing into a balloon. You have to force air into that balloon to get bigger, but you don't have to do anything when you let go of the valve to let air out. Tidal volume is the amount of air moved in one breath. It's how much volume actually goes into your lungs. Inadequate tidal volume, when we get more into positive pressure ventilation, it's mostly looking at chest rise and fall. If you're getting chest rise and fall, you know you at least have some sort of adequate volume. In flight and in the ICU, we have to actually calculate all of our vent settings and what we're expecting our patient to pull for a tidal volume. And these are all height-based because of how the normal human body is made. Just because someone's smaller, if you have someone that's 6 feet tall and 100 pounds, and someone who's 6 feet tall and 600 pounds, their lungs are relatively the same size. Just because they're bigger doesn't mean their lungs need more. Just because they're smaller doesn't mean their lungs need less. There's other properties that can influence whether you need to give them a little more or less. But typically, as long as you're getting chest rise and fall, you're having at least enough adequate volume to fill those lungs to participate in adequate gas exchange. When we talk about minute volume, it's the amount of air moved into the lungs, in and out, per minute. Minute volume is affected by two things, and it's right in the calculation for it: tidal volume and respiratory rate. If you affect either, you're going to affect their minute volume. Because you're either going to be giving them more air in a volume or more breaths per minute. Same, less volume, less breaths per minute. You can couple that, and then you're going to have a drastic change in minute volume. If we had to say, is it more important to have a minute volume versus a tidal volume? It's minute volume, because we care about how much they're actually getting in that full minute. Whenever we are helping someone breathe, whenever they're on a ventilator, and even as we breathe, each breath is different. So each breath that we take has a different tidal volume. The way that helped me kind of understand whether minute volume or tidal volume was more important, think about it like cardiac output. Your minute volume is your actual cardiac output, how much you're actually able to move blood to get to your organs to perfuse. And your tidal volume is like your heart rate. It's going to constantly change. It's going to affect that cardiac output, but it's not the primary determinant of how much is actually moving per minute. So when we go to bag someone and we're thinking in ideas of minute volume, we're going to be thinking, how much air am I giving them and how fast am I giving it? Dead space is the part of the respiratory system that does not participate in gas exchange. The respiratory system starts in your nasal cavity, oral cavity, moves down, right? And then between your upper and lower airway, you have that glottic opening. Most everything below that glottic opening is what actually participates in gas exchange. Dead space is important because as we ventilate, as we're helping the patient breathe, we have to remember that all the air above that glottic opening, you're losing oxygen, and it's not going to be able to participate in gas exchange up here. It has to get down into your bronchioles and alveoli before it actually ventilates. So when we're adding more and more things on, like the supraglottic airways, an ET tube, end tidal, additional tubing, all of that actually increases our dead space because we're increasing the amount or the distance that all that air has to go before it actually gets to the part of the lower respiratory system that participates in gas exchange. So the respiratory system, again, starts up here, moves down, but not all of it exchanges gas. The parts that do not is called dead space. Anatomical dead space is the dead space in your body. Everything you add after is just additional dead space. But that's what dead space is. It does not participate in gas exchange. This is especially important in peds patients because they have less room for errors to happen. And they also need more pressure to keep their lungs open. And then alveolar ventilation is just the amount of air that reaches the alveoli once you get past all of that dead space. Those are kind of the basic terms and concepts that your book starts out with, and the basics before we really get into more on ventilation. Does anyone have questions on this basic slide? So before we talked about in our outcomes that there's also cardiopulmonary concepts that we need to be familiar with, or we need to understand how our cardiovascular system and pulmonary system play with each other. A VQ match is ventilation and perfusion. V is for ventilation, Q is for perfusion. The Q comes from some Latin word. Don't ask me what it is, but that's where the Q comes from. So it's thinking about how much blood is able to get to those alveoli and how much we're actually being able to ventilate. A normal VQ match is 4/5 or 0.8 for the ratio. And a lot of times we think, oh, it should be 1-to-1. We should be giving the same amount of blood to the same amount of place that we're trying to exchange oxygen. It's really close to 1. Sometimes it's a little bit higher than 0.8. The difference is that blood follows gravity. So you'll always have a little bit more blood pooling at the bottom than you are actually having gas exchange. So you'll always have a little bit more perfusion than ventilation. And your alveoli are covered in all of these tiny little capillaries that help to get blood to it and that help to move all the gases that are being exchanged. Your alveoli work in a process called diffusion. Diffusion meaning something is going from a higher concentration to a lower concentration because it's moving and exchanging all of those gases. Diffusion is typically a passive process. When we think of high to low concentration, it'd be the same thing if I were to sit here and spray a bunch of perfume. The people in the front are going to smell it more, but as it diffuses in the air across the room, the people in the back are going to smell it less. Pulmonary respiration is the diffusion of oxygen and carbon dioxide between the alveoli and the circulating blood around it and within your body. Cellular respiration is that diffusion of oxygen, carbon dioxide between the actual cells in the alveoli. So there's 2 types of respiration, but they all kind of function to do the same job in terms of getting that gas exchange. We want oxygen in, and we want our waste product of carbon dioxide out. All right. Before we talk about all the different ways, maybe here, to administer oxygen, calculate oxygen availability from your tanks. Again, it's important to talk about oxygen, not in only the good ways, but the ways that you can harm someone. Because again, oxygen is a medication and it can cause harm. It should only be administered based on your overall evaluation of the patient's presentation and possible underlying cause. Sometimes you'll also have those patients that say, I think if you put some oxygen on me, it would make me feel better. And then they're going to want more and more and more. Listen to your patient, treat your patient, but also make sure that if for some reason it's making them worse, like in COPD, that you have to educate them and just tell them why I'm going to leave the oxygen where it is. And then try to treat their underlying cause and focus on that instead. And then you're going to titrate based on the patient condition and the desired effect. Whenever we might have longer transports, we can still titrate that oxygen down. Typically short term, you just want to make sure they have enough oxygen and you want to get them to the hospital. You can cause oxygen toxicity and air collapse. In your book, it talks about underlying factors that we don't always know about that can harm people, especially with conditions such as MIs, so myocardial infarctions or heart attacks, and strokes. The underlying complete pathophysiology isn't known, but we do know that when you give someone too much oxygen, especially for prolonged periods of time, it can actually increase free radicals in your body, and those are really bad. And those can go to harm the body even more. With little infants, especially preemies, neonates, newborns, when you give them too much oxygen, those free radicals, along with some other processes, can actually cause damage to their retinas, and you can permanently blind them. Again, COPD people breathe because they lack oxygen, because they live in a high carbon dioxide environment. We breathe not because we necessarily lack oxygen, but because our carbon dioxide is too high and our body is trying to get rid of that waste product. So that's where your COPD patients, you might ask them again what their baseline is. Typically, they're not going to know their baseline end tidal, but they might say, I hang around 84% all the time. So if they're like, and I wear 4 liters at home, if they're 4 liters and 84%, keep an eye on them. That's abnormal. But again, just because something's abnormal doesn't mean you need to go and fix things right away. Because if you put too much oxygen into a COPD patient, you'll tank their respiratory drive because you're giving them too much of what they need to tell their body to actually breathe. And then the exacerbation of other conditions was the free radicals, the MI and stroke example. Your book talks about, and it has a really good diagram, I believe it's table 10-4, where it shows adequate, inadequate ventilation, and then respiratory arrest. I think there's a couple pages on it. I think we've talked about it quite a bit. Adequate, airways intact and patent. They're able to speak in full sentences. Their oxygenation using your SpO2 diagnostic device is adequate. Inadequate breathing, they have gurgling, stridor, they're hunched over, they're gasping. Your O2 is low, you're having to add more and more oxygen. And then respiratory arrest, they're not breathing, essentially. The part that you might hear, or at least in nursing we talk about, is respiratory failure. Respiratory failure is the very extreme end of inadequate breathing. If you hear anything about respiratory failure, it should cue you in that the only next step is respiratory arrest. Children especially, this is important to note. Children do that cliff dive where they're like compensating really well and things seem fine and then they tank, compared to adults where it comes over time. Children are more likely to code from respiratory failure to arrest than something cardiovascular related. I'm not saying that you're never going to have a peds patient where it is purely cardiac, but kiddos and how much their body demands from their metabolism for oxygen is much higher. And so they have less reserves as well. That's a really big thing in PALS in test questions that I've seen in all kinds of tests is you're going to support that kiddo's respiratory status really before you start focusing on their cardiac status. If you guys have more questions on the adequate, inadequate, and respiratory arrest, please ask away. A lot of it depends on your assessment, your vital signs, what they look like, and how you're treating them. And then again, it's always about trends. Someone could have inadequate breathing. Your paramedic or the ER could give them, some oxygen nebulizers, racemic epi, and they can do better. Their trends get better, or they can get worse. And then you're always thinking, is the airway intact and patent? And will it stay that way? And you're going to anticipate if it doesn't, what you're going to do.
Kind of one of the test questions I used to be on National Registry, I'm not sure if it still is, but it'll ask you what is considered inadequate breathing, and it's a respiration below 10. So normal breathing is what? 12 to 20, right? So anything below 10 is considered inadequate. And so that's why when we're doing cardiac arrest and stuff like that, we're looking at providing ventilations at 10 to 12 minutes. That is within that adequacy, and it's not overloading them with oxygen. So keep in mind.
Something that Jim just reminded me of too, inadequate breathing, we can think of less than 10, but also if you have someone who's breathing 70 times a minute, it might be adequate to get them there now, but that's not sustainable to life.
I think there's a high number, but I can't remember. 28 comes to mind, but I don't think it's that high.
Yeah.
So it's like anything above 24, I think is considered inadequate on the high side. So but I'll look that up and make sure.
Yeah, because then they'll get fatigued. And when someone's fatigued like that, and they have other underlying conditions, they might have waited for help, then they're just going to go into failure and arrest very quickly. So you also have to think about where my patient can breathe this way and breathe pretty fast now, but is that sustainable, especially for those kiddos? Oh, we're good. When we talk about oxygen delivery devices, this is kind of the breakdown, least amount of oxygen to most. You could kind of say it's important to look at the flow rate because not all devices will be able to administer their supposed oxygen concentration at the incorrect rate. Doesn't mean that you can put more or less into each of those devices, but it might just not be as efficient or equitable. So nasal cannula, you have the two prongs that go into the nose, and then it wraps around the ears. Please always make sure that you're using the right-sized prong for the right-sized patient. I can't tell you how many times I've seen an adult and you go to like fix your nasal cannula and someone put a peds nasal cannula on them. That's not going to do much for them. And it's also going to dry their nose out. So if someone's on higher and higher and higher oxygen, we're going to talk more about humidity, but just keep in mind that it is very dry. So only oil-based products in there. A lot of your people on long-term oxygen will shove Vaseline up there to help. But again, Vaseline, petroleum, flammable, oxygen, flammable. It's not going to help in the long term if something bad happens. Because you will see that smoker that's huffing and puffing with their oxygen in, with Vaseline in your nose, and you're just going to be like, I'm going to walk away now, because you have to keep yourself safe on that scene. The nasal cannula will also have a little attachment at the end that you can shorten or tighten just so it sits up against their chin so it's not consistently falling off. In some of your peds patients, they'll just keep pulling it off. You can put little pieces of typically paper tape on their cheeks and then sometimes right here under the jaw to help get that patient to keep the oxygen on. And also with your peds patients, always talk to their parents. The more you can get the parents involved, it's going to help everyone in that team, from the parents and patient to you, respiratory therapist, your partner. And it keeps them active in care and helps ease some anxiety as well, because then they have a little bit more control and participation than just watching someone put oxygen on a child. And my kid had oxygen, I would be a little bit anxious and nervous. So a partial rebreather mask, oxy mask, is also kind of similar. The mask that goes over the face, you put the straps around. The oxy mask will have holes in it, but there will be no bag attached to the bottom. A non-rebreather mask will have a mask with no holes and the bag at the bottom that will inflate with oxygen. Tracheostomy mask goes over a trach. Typically those patients, especially if it's long-term, is probably what you're going to see around this community. They'll probably have it set up how they need to. But it's the same shape as the simple mask and it goes right over the trach. A Venturi mask, there's a good picture of it in your book, but it allows for some carbon dioxide to actually be re-inhaled. Those are going to be best for things like your COPD patients, where you don't want to put them into a high oxygen, low CO2 concentrated state. A CPAP or BiPAP is a mask that is going to have a seal against the face and then typically multiple straps that go around and then into the machine. Whether it's a CPAP or a BiPAP, it's going to help add a little bit of pressure into the patient's lungs to help ventilate them, push fluid out of the lungs to oxygenate them. CPAP is typically what's carried on all ambulances. That's also for people with sleep apnea. They'll wear those because it's providing pressure on inspiration when they breathe to help ventilate and oxygenate. BiPAP, bi like two, will provide some on inspiration and exhalation. And that's the difference in the two. The CPAP for your sleep apnea patients is typically to have their body trigger to breathe when they stop breathing at night. Blow-by oxygen typically is referring to infants and peds. It's where you have a mask about 2 inches from their face and you let blow-by go in. But with blow-by, you're never going to officially know how much oxygen you're actually giving that patient, because it's not secured on their face and all that other oxygen is getting lost around them. And you can say, hey, mom, hold this 2 inches above the kiddo's face, but the kid's going to be moving and the mom's going to be moving. So it's not always consistent in how you're delivering it as well. But that's what blow-by is. When you guys are out in the field, this again is kind of a progression of them getting worse, what you might use for them other than the blow-by. So if I put someone on a cannula, they need a little bit more. I'll put them on a mask, they need a little bit more. Then they get put on a non-rebreather. Every time that you change an oxygen device into something that requires more liters per minute to get more of an oxygen concentration should be kind of a red flag in your mind of, why are they needing more oxygen? Why am I changing the device? And can I do anything about it? If you guys show up and your patient's talking to you, but they're 50% and on no oxygen, just throw them on a non-rebreather, get their oxygen better. Don't say, let's see how you do on a cannula, and then we're going to put you on a mask. If they're that low, again, it's the same thing of like the airway adjuncts. You're not going to go in order. You're just going to give them what's going to give them the most and most adequately treat that patient right then. When we monitor end tidal with the nasal cannula, it'll be the green one going around, and you'll see a little flap between the prongs. That's what helps measure your end tidal. Because again, from our vital sign chapter, there's 2 ways to measure end tidal, and it's that type of cannula with the flap right here, or it's through that plastic connector that goes into your supraglottic airway, trach, or ET tube. Yeah. So again, the non-rebreather is the mask with the bag. Yes.
Below 10 liters, bag is going to eventually collapse, and it's not doing them any good. So you got to make sure you're at least at 10 liters to keep that bag inflated. You're going to inflate that bag prior to putting the mask on, prior to putting your finger over it, and that'll help inflate it. Carefully, do not blow that bag up. It will pop.
Yes.
And it'll scare the crap out of the patient, you, your partner, and anybody around. Sounds like a gunshot. It's loud.
So being familiar with your oxygen delivery devices now before you go into clinicals, if your partner's like, hey, I need a non-rebreather, and you're like, which one is it? Which mask is it? I know it's a mask. It's the one with the bag at the end. Similar to how Jim's talking about, that has to be at least 10 liters to work. If you take a regular nasal cannula and put it up to 15 liters per minute, it wasn't made for 15 liters per minute, so it's not going to do anything more than your 24 to 44%. You can crank it up to 15 liters and then put another device on, but ideally the efficacy again is these devices were made for certain liters to deliver certain amounts of oxygen. So if you're like, well, their nasal cannula is at 6, I should probably be thinking about a mask next. If you're like, well, I'll put the nasal cannula to 10 and then to 15, that's not necessarily the best way of thinking. You should think, okay, I'm on a nasal cannula, I got to 6, the patient's 78%, let's move to a mask. And then you start the mask at the 9 to 10.
All you're going to do with nasal cannula jacked up that high is better than nasal test.
Yep. There are high flow nasal cannulas, so they have slightly bigger prongs, bigger tubing, but those typically require specifically humidification because you're giving more oxygen and drying their nose out. If you're going to give them that high flow nasal cannula, you're going to put that humidifier on. So a nasal cannula can go higher, but it's a different type of nasal cannula. So I didn't want to put that on there to confuse people. And typically for transport, I think a mask is just easier than hooking up a bubbler, trying to keep it clean. But you might see those when you go into the ER. Yep.
Main thing is you're going to want to know for testing purposes for us and National Registry is what the liters per minute for your nasal, your partial rebreather, and your non-rebreather. You might hear the partial rebreather called simple mask at times. Some of these doses are a little bit off as far as flow rates go, but the delivery percentage is correct. So nasal cannula is 1 to 6. Partial non-rebreather or a simple mask is 8 to 10. And then non-rebreather is 10. Did this one come with the book or this one?
I think I copied most of it from the book.
Yep. So if this is what your book says, go by this. But as far as National Registry, just kind of know the 1 to 6, 8 to 10, and 15.
When we talked about flow meters yesterday, and when they hook onto different oxygen tanks and bottles, I've been to a bunch of different hospitals now with flight, and you will see there's like, I swear, hundreds of different regulators and flow meters out there, but all of them are very different, and some of them will only go to 6. So if you have someone on a portable oxygen tank or one that's sticking into the wall, make sure if you're on longer transports, if you're anticipating the patient needs higher oxygen, that it actually goes to how high you want. So when you get into your practice, don't be afraid to look at the different flow meters to understand how to make sure you know how much oxygen is getting through there. Any questions on oxygen delivery devices? All right. This is what I was always trained as. In my ICU, we call it a PACO tool or PACO tool. It's how you're able to calculate how many minutes of oxygen you have based on how many liters per minute the patient is taking it and what size tank that you have. So it's the gauge, the long formula is the gauge pressure in PSI minus your safe residual pressure, which is 200. That's your constant. It's like the safest minimum, times the constant of your tank. And all of those numbers are the constants to different sized tanks, divided by the flow rate in minute. So how much liters per minute you're giving your patient is going to give you the amount of minutes that you have for oxygen. So if you're taking a patient to Denver and you have, say, the gauge on your tank says 1500, you're going to subtract it from 200 and you're going to have 1300. Say it's are you guys just M tanks in the main?
Are the ends the ones that go in your crop, your rooms?
Those are E's.
Yeah.
The D's are, no, I'm talking about their rooms underneath the,
Yeah, that's an E.
oh,
Yeah.
So ours are D's, so we carry
the
on
little
the truck.
ones. And in the case, the big one, we only have a high.
And then I think ours, the small one is either an H or
One that goes on 229.
So the big one's K though.
the big one's K.
Okay. So you look on your tank, your K tank, the big one in your ambulance, and your pressure gauge again reads 1500. You'll subtract that from the constant safe minimum, which is 200. So you're going to get 1300 for that first parentheses. Then you're going to multiply it by the constant of your tank, which is a K tank, 3.14. And you're going to get 4082. So you have 4082, and say your patient is running 10 liters per minute. You're going to divide that by 10. And that's how you're going to get that you have 408 minutes of oxygen that you can give that patient at that flow rate. And Denver's 2 hours from here? 3? So minus 3.
You had 6 hours.
180.
6 hours.
Yeah. So you'll have 228 minutes that you can anticipate you're going to use. So we always do a PACO tool every morning as part of like our crew checks. And then whenever our waters is set up, that's literally the first thing you ever chart. Because you don't want to be, especially in Wyoming, where things are rural and things are very far apart, especially medical facilities. You don't want to be down the road in the middle of nowhere and have no oxygen. Same thing, we don't want to be stuck in the middle of air, in the middle of a field with no more oxygen. So that's how you can calculate your PACO tool. But just because you calculated a PACO tool and you know that at 10 liters per minute that patient's going to make it to Denver, still be thinking they're on 10 liters. That's quite a bit of oxygen. Why are they on that? How long have they been on that? Because you don't know when that 10 liters is going to turn to 15. So we were always, sorry, go ahead.
How do you know what size tank it is? It says on it?
No.
Yeah. Some of them do.
So, like this thing here.
Does it have like a gauge on it? How much
Yes.
is in it?
Yep. We're going to go over how to switch regulators and stuff next.
That are on, that you see on the x-ray, and then they're about this long. Those are e-tanks. So mostly determined by size. Looking to see if this one's set it. That's another e-tank. These are the ones that are currently on our trucks. This is the one you'll be using for class, because they're going to want to know that you can put this on.
Don't worry.
Can we do that next?
Don't do that. No, don't do that.
And what is our tank on?
I think that one's an M.
It could be there.
What is?
Do you have the, oh, this one's just push.
Nope. It's 5, 6, 7, 229, or 226, all the same size.
Do you have the,
Oh.
I'm looking for, I use my scissors, but I don't have my scissors. My scissors have a thing for it. Do not take scissors, or just turn that thing.
Put up there here.
Yeah, they're.
I don't know if I've ever seen that, but I probably will now.
So the wrenches will look like this. If you go into a house that has one of these, they're usually attached to the tank or nearby it.
Lynn Carrick especially always kind of keeps one close by too. Oh,
We haven't filled it yet.
That's my tomorrow task.
so this is empty.
That's what I was planning on doing.
That's not how you test to see if it's empty, but there's a weight difference to it. So this is your oxygen bottle, D-tank, portable. This is your regulator. So this is where it's going to tell you the PSI. And then this, you can see the window is going to tell you how much oxygen you're actually giving that patient. So this one goes all the way up to 25. So things like ventilators, you can crank it up, but sometimes there's like halves and like quarters. I don't know why those exist, but this is actually this is how you actually tell how much liters per minute you're giving your patient. This is how you tell how much oxygen's left.
You're running a PEDS, with PEDS nasal cannula. You can run this at a quarter, 0.5, and I think after that it's. So you can run it below 1. It's just you're only going to do that on entrance usually.
When you look at how to switch out a regulator, please make sure first that this is marked that it's full. Typically there's a cap that goes over that you have to break. They'll be in a different section, but make sure that you understand wherever you're doing your clinicals or wherever you work that you are getting a full oxygen tank bottle. There are plenty of places where these will be empty next to full ones, next to half full ones. If you can, try to make sure you know which ones are full. If you look on the side here, there's 2 small holes and then 1 big hole. If you look in the center of this, and when you go to practice, there's 2 small ones on the bottom and 1 big one up here. It goes over and you line it up and it'll kind of seat itself once you get in there. And you tighten that part. And then to actually turn it on, you have these that fit up here and then it's on. You don't have to sit here and turn it like you're working on something on a car. It's just turn it on. Your book says go, and then it's a half turn back. And then because you're awesome people and awesome teammates, you're actually going to turn it on to make sure you're getting flow out of it. And then this one is obviously empty, so you can't hear or feel anything, but that's what you're going to do. You're going to change it, turn it on, check the gauge, and then make sure that you can actually get flow. There's been a lot of times where these don't get put on right. The oxygen has actually been turned off the whole time. No one's checking the flow. So all of a sudden people are like, oh my gosh, this person's 50%, their oxygen's horrible, and they're freaking out about all these other things just because the oxygen wasn't turned on or connected right, or the bottle went empty. So just because you changed a regulator out doesn't mean different things can happen. Always make sure that it's still actually functioning properly. This is just how I do it, is you will meet people that don't always do this. I turn my oxygen on every morning when I check this on my rig, and when we had our different setups in the ICU, you check it. Yep, we'll say it's full. Checked it, I'm getting good flow. And just so it doesn't leak, I turn it off. And then if you push, oh, this one doesn't have a pressure valve. Sometimes some of them will have a little pressure valve. You can push the pressure valve and it'll mark it all the way to 0. So then you're not worried about a leak, or if it's actually right. Things get checked, and you know the bottle's off.
And on your paper, you're required, once you twist it to make sure it's locked in there, you're gonna listen for a leak. Sometimes you can hear a little bit of coming out, so then you would say, I think I have a leak, I need to check, make sure my O-ring is still attached. Some of those actually come with a little O-ring that goes in where the nose is on the smiley face.
Yep. And then if you leave a bottle on, even if it's not leaking, all of the oxygen in this tank is susceptible to pressure and temperature changes. You might have a full bottle at 2000, gets left out in the cold for a while, you left it turned on, and all of a sudden it reads 1000. It might just be a pressure change, not that it's actually lost half of its oxygen because it had a leak. So if you keep it turned off and you know for sure that there's no leaks, then you should know that you have a full bottle and that you're ready to go when you need it. If your partner's like, hey, we're going to have to go into the ER, can you put them on the portable oxygen? And you're like, yep, please make sure that it is turned on before you do anything. This will be one of the first things that you check, because a lot of times it's just turned off because we don't want leaks.
And if you're paying attention to Lexie, you'll pass your oxygen administration.
So one of the things that wasn't covered but is in your book is before you put the regulator on, you're gonna take your little, usually it's a white piece of tape on this style. And when we get a fresh bottle, if it's got it on it, we'll leave it on it until class. That way you guys can see what it looks like. Once you take that off, you're gonna crack it before you put the regulator on and blow any dust out of that port.
That's the regulator in your hand right
Yes.
Yeah.
now. So it comes with that top thing on it?
No,
You have to put that on.
This
too.
is it.
That's what?
that's what you're gonna get.
Yeah.
Initially.
You get a new bottle, this is what it is. That's all it is.
And that tape that they're talking about is either white or blue or bluish green or whatever. It's actually going to go over this so as to try and not get dirt and stuff
Oh,
in it.
yeah, that's what I meant. Okay, so it comes with that top on it.
Yeah, this is
Not the
connected,
thing.
not
that
the
was in your
regulator.
hand. Yes, that's the regulator.
And then some of the older style ones do have, like the O-ring is more inset as opposed to this one is kind of flush with this part. Like there's no indent in here. So
Your O-rings might be plastic or they might be brass. It's important to make sure you have that on there. If you don't have that O-ring on there and you put this on, it's going to leak. and you're gonna hear it when you crack it. So if you crack the top of this thing and you start hearing, but you got the regulator on, it's tight, give it a like quarter turn more, just to make sure it's tight. You still got that leak, turn it off, take it off. Either your O-ring's bad, you've got it in cocky, you put it on backwards. There's a lot of things that could be why you're getting leaks. So
This will be easier to see when you guys can actually come mess with it, but we can pass it around. So let's do a practice calculation.
Don't lose your. Exit. It's a bubble.
There are other ways to do your PACO tool or your PACO tool. So if someone does a little different, there are different ways of doing it, but this is your book way and a very common way of doing it. So we're going to be awesome in practice again. This is a D tank. I'm going to say your pressure gauge is 1,000. And your patient's on 15 liters. D tank, yep. So your gauge pressure is 1,000. You have a D tank and you're running at 15 liters per minute on this patient. So I'm just going to talk it out now, if you guys are good with that. Y'all have a number. I don't like stump the chump or calling on people. I didn't like that as a student. Just don't like it in general. So again, 1,000 PSIs on your gauge. The D tank and 15 liters per minute. So we're going to take 1,000 and subtract it from our safe residual pressure of 200. And we're going to get 800. Then we're going to times that by our constant for a D tank. D like delta. So we're going to say 800 times 0.16. And we're going to get 128. And then because we're running at 15 liters per minute, 128 divided by 15 gives us about 8.5 minutes. If you guys need help with that, please see us at break or during stations. I couldn't find a better way of writing this because I could not figure out on Google how to put divided by on the bottom to make it look nicer. So I'm sorry, there's a bunch of parentheses and stuff. Also, we talked about cognitive offloading. One of the tools that I carry around in my pocket at work is a PACO tool. That's a straight up table with all the tanks on it, so all the math's done. So all I have to do is look at my table and go to D tank, 15 liters, and it'll tell me how many minutes it is. So if that's something that you can find on a rig, or that you just want to keep kind of in your personal stash that you may carry around, that's a good way to cognitively offload. It'll speed up your rig check. And then if you have it available, if your patient has oxygen changes en route, it's very easy to look at just a simple time calculation. Also, we can do these calculations, but please again, say we're like, oh, we have 8.5 minutes. So we just did this calculation at urgent care and the patient only has to go from urgent care to the ER, which is a hop, skip, and a jump away. But please also think that like it's going to take you time to get the patient on the cot, to get the cot to the ambulance. The patient's probably going to want 4 blankets before you leave. So you're going to put 4 blankets on, and then you're going to get to the ER, then you have to offload that patient. So even if you're like, oh, I can make the time between A and B, there's a lot of other things that can happen. So maybe try to find a different tank or find a different route in terms of how you can help that patient. Does anyone have questions on a PACO tool? We want to break? All right, let's break. All right, guys, we're going to talk. Where the hell did my clicker go? There we go. We're going to talk a little bit more about oxygen and oxygen therapy equipment. When we talk about this tank, there's the always and nevers that your book gives. So always use the pressure gauges, regulators, and tubing that is correct for the patient and the device. Not all of these will have the nose and like the smiley face, kind of like JJ's talking about. Make sure that whenever you are using the rings that turn it on, they're actually made with non-ferrous material, meaning non-iron containing material, so that doesn't spark. That's why the metal is in them is different, and that's why they're specifically made that way. Make sure that you use medical grade oxygen. Don't know what else you're gonna get. Store in cool, ventilated rooms. Keep upright and always have secured. There's always the rumor of like, oh, if I suddenly like tipped this bottle over and it fell on the floor, it would like shoot out and explode. That's the more drastic version of it, but it is pressurized. It is flammable, so please take care of it. It is absolutely okay to leave it somewhere upright, but make sure that is not a high traffic area, that no one's going to come over and bump it. You're not leaning it up against a wall. If it's on a stretcher, please make sure that if you put it on like the back, if it's secured on the front, that it's in the correct securing Velcros, or you are 100% positive that oxygen bottle isn't going to fall off. Something that your book did not talk about that you might encounter somewhere, because I know it's happened multiple times in Douglas while I was here, specifically in the ER. These are metal. Metal does not enter MRI rooms. So there is the horror story of a little kid with brain cancer, beat brain cancer, and he goes for his last MRI ever. This is a real story, and it's part of nursing training. A lot of places went for his last scan. He was on a little bit of oxygen because he was sick and he needed it. Someone wheeled him in there, and then they brought in a oxygen tank into the MRI machine that is a super magnet that is always on, and it crushed his head and killed him. So if for some reason you are anywhere near an MRI machine in a zone, a lot of times you'll go to different places. You could drop the patient off in Denver and they're going to be like, that patient needs a head CT or a head MRI right now. We need to get to MRI. Metal does not enter an MRI machine room. There's different zones for how that magnet reaches. So if you're in zone 1, less magnetism. If you're in zone 4, that's like right in the machine and in that area. Please make sure it is all MRI equipment approved. They will have different tanks and different equipment. But these are metal, and the magnet in an MRI machine is always on. Okay, please do not forget that. Then again, always check that you have the right tank, the tank is on, you have the correct adapters, you followed all the steps to correctly making sure that your tank is on. Then when you're on the ambulance, please make sure that your oxygen is turned on in the back for your partner as well. Never, I think we talked about that, smoking, use greaseless and greaseless tools. No adhesives attached to the tank. I've seen plenty of tape on a tank, but ideally that adhesive can also set fire. That's what they say. If you want to move a tank, please lift it, carry it where it's secure. Don't drag it or I've seen people roll it down the hall. Please do not do that. There's time for fun, but not with oxygen tanks. Alrighty. Notice how it is upright, not leaning against the wall in a non-trafficked area, for example.
For your practical portion of oxygen administration, you'll put the regulator on, you'll hook all your stuff up, you'll check it, all it checks, and you'll lay it down, just because that is part of, I don't know if it's critical fail on that, but it is part of that thing, is that you lay the tank down. And that is just to keep it from getting tripped on. But we've dropped these plenty of times, haven't had one rip through them. The K tanks, we don't move those unless they have the safety.
We're gonna be best practice. And then we drop it, we're gonna, oh, and it's like, that's fine. No one saw that, right? All right, oxygen therapy equipment. It's the cylinder, it's that regulator, the part that you're gonna put on it and practice with. And then the delivery device is the nasal cannula, non-rebreather, Venturi mask, whatever is actually connected to it. And then that's just the amount of liters of oxygen that each holds.
Full tank should read 2,000 PSI.
Your book had the liters in it, so I included it in the PowerPoint.
All
All of them. All the regulators, if it's maxed out, we'll say 2,000.
Oh,
And then when you use your PACO tool, it's different in minutes, even though the PSI is the same for each regulator, because it's how much that tank holds in the conversion factor. When we talk about adding humidity to an oxygen delivery device, there's a picture in your book that's pretty good. It'll screw on to where the oxygen regulator is, and then the device will connect into that humidifier bottle. On the bottle, typically it'll say minimum and maximum on it. If it doesn't have a minimum or maximum, I go about halfway, to be honest. But most all of them should be marked by now. You're only going to use sterile water to help decrease infection risk. 1 per patient. And then again, if they're on longer transports, if they're on that high flow nasal cannula, put some humidity on them so you don't dry their nose out. And some other thought. Typically, when you use a humidifier, you have to be running at least 8 liters per minute. So if someone's on a nasal cannula at 2, there's not enough flowing down into that water in that humidifier to actually give it humidity. So that's why with humidity, typically it's your larger 8+ liters per minute flow. Sometimes it works at 6, but that is like really pushing it to see if it works.
You'll see them on the concentrators at a little lower levels. Concentrators run a little differently than the oxygen tanks do. So you'll see those at 2 and 4 liters, but they'll just be on the concentrator, not on an oxygen tank.
Any questions on humidity? All right, artificial ventilation or positive pressure ventilation. For the purposes of this class, this is what we're talking about. We're talking about a BVM or bag valve mask. So it has the part that goes over the face, or this is the part that'll stick to an endotracheal tube or to the supraglottic airway, where you can bag them through it that way. You'll have the bag itself. Typically, when it comes in the bag that it comes in, this is all crinkled, and you're like, what is that? You just pull it apart like an accordion. You're not like this, crank it open. It'll just kind of unfold itself to where you can actually push air. And then this is the bag in the back, because similar to a non-rebreather, it's going to hook to oxygen. But the difference is this doesn't have to be completely inflated, but ideal it should be. This might not always inflate all the way because of how this moves in and out, but typically this will be completely inflated. And then you're going to attach it to oxygen. So instead of just pushing air through, if all you did was grab this, you're just giving the patient room air. You want to give them a little bit more with some oxygen. And that's where the oxygen attaches. Some of them will even just have it like continuously on there. And then all you have to do is take the tubing and then plug it into oxygen, then having to connect it to this first. Any questions on the parts of this? So this is a very basic BVM. Sometimes you'll see it attached to something called PEEP flow meter. Someone might say, can you attach PEEP to our BVM? This is a little different because this is for a different type of delivery device, but it'll look like this. It'll have numbers on it and centimeters of water is the measurements, and you can turn it up and down. So wherever this lid is where the number is, and it's giving the patient more or less PEEP. We're going to talk about more about PEEP in a little bit, but there's just, I mean, it's about that big without these parts, and it connects to the end of this. I don't know this to do this, but it delivers PEEP. And we're going to talk more about PEEP, but that's how you would measure it when you connect it to your BVM. We don't have the mouth to mask, I don't think. I know it's not always same concepts. You're going to position your airway. All of the concepts we talked about yesterday and with vital signs apply. You're going to be looking at blood, vomit, secretions. Do I need to suction them? Do I need to help position their airway? Depending on patient condition. You can still put an OPA or NPA in bag over that. They could have a cannula on. You can bag over the cannula. But what's important is that you're still getting mask seal with whatever else may be in or going on near their mouth or nose. So I don't want you guys to forget, whenever we're using this and talking about this today, you've already done all of your airway assessment. You've suctioned. Everything that applies to yesterday still applies to today, but today we're focusing primarily on positive pressure ventilation. Because you don't want to sit here and have the greatest seal ever and being the best bagger and you forget to suction and they have all this blood and secretions in there. So I'm not going to go over all of that again from yesterday, but just keep in mind as we talk about things today.
I have some questions.
Yeah.
Might be stupid.
You good girl.
If you put oxygen on that, how much oxygen do you put through that thing? Like
15 liters.
okay,
Or as high as it'll
no,
go.
on this BVM.
Yes. If
Okay.
they're getting BVM'd, that is not a good sign. And then also to get this bag to inflate, it's the same kind of as a non-rebreather, but it's because it's a little bigger, that 15 liters. You can put more in, but typically 15 liters.
So if they have a mouth tube, whatever it is, the OP, whatever, right?
OP,
What do you need to use that for?
to push air into them. So, and to give them additional oxygen. Because someone who needs an OPA, right, you've positioned them, put in the OPA, positioned them again, they still might need extra pressure to actually inflate their chest and get them to breathe. So if they've lost that respiratory drive, if they have some kind of spinal cord injury, if you're preparing them for intubation, if you want to make sure that they are breathing and that they are ventilating, that's what you're going to use this for.
So the times you're gonna use this, they're not breathing at all on their own. You're gonna use this, you're gonna breathe for them every 5 to 6 seconds for that 10 to 12 breaths a minute. If they're breathing inadequately, so below 10, you might use this to help maybe encourage their system to come back up. So you're gonna feel when they take a breath in that bag, you're gonna feel that bag relax. You got a good seal on it. So you're gonna give them a little extra squeeze with that, just to kind of see that chest rise. And then you're gonna count 1, 2, 3, And you're gonna figure out, you're gonna kind of know how many times a minute they're breathing. So if they're breathing 8 times a minute, we want to give them a breath in between those 8 times a minute to help get them to that 10 or 12 breaths a minute. And if they're breathing too fast, you can also use this to coach them to slow down. Usually you're going to do this on an unconscious patient. Trying to do this on a conscious patient is interesting, at least, but you can do it on a conscious patient. If you got someone who's unconscious, they're breathing 28, 29 times a minute, you're going to give them 1 breath every 5 to 6 seconds. And so that's going to kind of, that full breath might help them to start bringing their respiratory rate down. And so it's kind of, you use it kind of like a coaching device, but also you're helping them to get that the breaths they need, the respiration. So those are 3 times you're going to use one of these on a, in this type of way. Is CPR is in progress, they're not breathing on their own. They may have a pulse, but they're not breathing on their own. You're going to get them breathing.
Excellent questions. And with how the book flows is kind of how I did the PowerPoint. We're here in a little bit, we're going to go over, is it ventilation or hypoxia? Is the issue oxygen or their breathing? And that might help kind of get things a little bit straighter, I guess. So, but the mouth to mask is this kind of the same concepts of the 1-person rescuer. The only difference is that instead of this, you're gonna be breathing in there. Yep. So if they throw up because it's a 1-way valve, things go in, they should not come back out.
You don't use a 1-way valve or 1-way valve on that, is going to act like on one shoot everything straight up.
Yep.
And if you happen to be breathing at the same time,
You will.
Why would you have to do that? Breathe in that thing.
If for the mouth to mask, this isn't there. This is all you have with a 1-way valve.
Okay.
You are their bag.
Yeah.
So, and then
what we really don't go over in class, and it's not something you're tested on, because they're assuming you work on an ambulance, and so you're going to have a bag valve mask.
Okay.
Even law enforcement and the fire department carry bag valve masks rather than just a mask.
yes.
There's enough mission time to do.
Mhm.
So a lot of medical grade law enforcement, it'll have that 1-way valve in here. I remember I thought it was like so cool in nursing. I had this like little keychain with like a pocket mask on it. Those are not 1-way valves. I did not learn that the hard way. But if you want to be like tact a nurse like I was when you first start, it's not coming from a medical company. Just be wary of what that does. So when we talk about the 1-person rescuer, we're talking about something called the EC clamp, which is kind of in your BLS. So you make a C with your thumb and first finger, and then your E makes up these last 3 fingers. The mask, mouth is larger, nose is smaller, is going to get put on the patient. You're going to make a C kind of right around the lower part, and then you're going to use your E, the bottom fingers, to kind of press against the jaw and support it. That is your EC clamp. And you're going to kind of push on there to make sure you get a good mask seal. If they have a beard, then you can use water or a little bit of lube to help seal it better. And then again, guys, don't forget how you position your airway. If you have a morbidly obese patient and they got like 3 chins and you're like, what do I grab? You ramp them, get them better positioned. It'll give you a better hold to create a better seal. The seal is extremely important, so you know that all of that air and oxygen is getting into them rather than just escaping out the side. Because then when you're also trying to provide pressure, that needs a system that pressure can sustain, not off the side where pressure is leaking out. But that is your EC clamp. Does anyone have questions on it? When you give your breaths. For a 2-person, I was always taught it was the 2 thumbs up rule. This is the ideal way that you want to be able to get the best mask seal possible to get them intubated the best. But obviously, when you got 2 people and it's just you guys and the patient, that's not possible because other people are going to need other things. But again, a lot of times it is a team effort. There's other people there. So if you and your partner are working on them and you need someone else to bag them and you got 2 firefighters, it is very easy to teach someone the 2 thumbs up method. You put the mask on as you would. You take your 2 thumbs and you press the mask down on the sides. And then now, because you have more room in how you're positioned, you can actually do a jaw thrust at the same time. So you are absolutely maintaining position while getting a good mask seal. So if Stacy's my firefighter and Jim's like, hey, I need you to go get another tourniquet from the bus, I could say, hey, can you come over here? All I need you to do is put 2 thumbs as hard as you can on that mask and lift their jaw up a little. And then your other firefighter buddy is going to come over here and they're going to bag. Say 1 breath every 3 seconds, 1 breath every 6 seconds, depending on patient need, and just till you see chest rise and fall. But the 2 mask, I'm at the head of the patient, so I understand where the seal is. Sorry, I have 2 thumbs. 2 thumbs down, and then you got room for a jaw thrust. Yeah? Any questions on it? When we talk about actually giving breaths, we have our seal. A lot of times people like to go like this. They want to give the best breath ever because they are breathing life into that patient. You're only doing enough to do chest rise and fall. If you're one of these people, do any of you guys ride motorcycles? Well, when you don't want to be like full thing on the throttle the whole time, they teach you like the ice cream cone method. So you hold it like you're eating an ice cream cone, 3 fingers, guys. Or even 2. If you feel like you're getting overzealous, 3 fingers will help you not think as full throttle. But it's only until you see chest rise and fall, and then you release. And then you can count. Don't be going like this. If you go like this, and all that extra air is there, it's going to go straight into their stomach. And when your stomach expands more, it leaves less room for your diaphragm. So then it causes more problems for ventilation as well. But it's just as much as you need for chest rise and fall to get that adequate tidal volume, which is how much volume you're getting them with each breath.
You gotta remember these bags are 752 to 1,000 milliliters. So the normal person's lung capacity is 400 to 550. So if you're shoving that entire bag into there, you're over, you can go on, go over and place the lung, or you can shove it down into the.
Guess if you have some really tall person that needs it. I'm sure there's a reason, but
Easier to make something big.
Yep.
Than it is to make it this big. So like the little pediatric one that you saw floating around the other day, that one's about 250 to 300 milliliters. And the baby is like
minuscule.
100, I think.
Yeah.
So they're all made a little bit different.
Oh, I guess you could leave that on. And like Jim's saying, how you can pop a lung and you can cause problems for a patient. PEEP is positive and expiratory pressure. We all live at a baseline PEEP of 5. PEEP is the pressure in our lungs that keeps our alveoli open for gas exchange. So if we need to increase PEEP to try to increase oxygenation, we're helping those alveoli to expand to have more gas exchange. Too much PEEP can hurt a patient too. It can burst those alveoli. And PEEP has pressure in it. So we're like, oh my gosh, There's all this pressure. I'm going to make their lungs explode. You're more likely to hurt someone's lung, to pop a lung, by giving them too much volume because you're overfilling it compared to actually having too much pressure in there. So PEEP and volumes and all these get thrown around a lot when we talk about ventilation, whether that be with a respiratory therapist, paramedic, with a nurse. You are more likely to hurt them giving too much volume than you are by giving them too much pressure. Your alveoli can withstand a little bit more than just straight up shoving a whole liter into a lung that only holds 500 milliliters. Also, guys, when you are bagging someone, it's probably a really bad scenario like Jim's talking about. They weren't breathing, they had inadequate breathing. There's gonna be all these other things going on. You're gonna be watching it. You might be giving a breath every 3 seconds. But please make sure if you are in charge of airway, airway is probably most important at that point. It is your A of your ABCs. Focus on it. The last thing you want to do is then you're like this. You have no mask seal. You're not helping that patient. Or you're giving them a full breath. I'm watching Stacy start that IV over there because she's like kick ass with getting blood. And next thing you know, I'm like, oh, I don't need to be giving them the full breath. Same thing if you had a tube down this guy. Your partner intubated, tube secured. You can just slowly bury that tube by not paying attention. And then you're only inflating one lung probably. So if you're up here, please pay attention to what you're doing. This is a very important job.
You can also pull that tube out.
Yes.
You want to make sure that when you're doing it, I always tell people when they're intubating to hold them out. And that way they're not pushing down on it. They're just bagging up here. And then if you're holding it up here, your inclination is to go to make sure you're on that thing. So you're either pushing it down, or if something happens, you back up and now you just pulled that tube out. So you don't actually hold on to the tube and just sit there. And it helps. So when you're bagging these people, you want to bag them at about one breath every 5 to 6 seconds for an adult, every 2 to 3 seconds for a child. When you're bagging them for CPR, it's pretty easy. You're going to be listening to the person who should be counting out loud while doing CPR. When they hit 30, the minute they come up from that 30, you're going to squeeze 1, squeeze 2. And then they're going to go right back on the test. Should take less than 5 seconds to do that. That way you're not losing that CCF. I know we talked about in BLS class. So the quicker you get those breaths in, you want to make sure you get full expansion of the lungs or full exhalation of the lungs before you give another breath. But you want to give that breath over 1 second, give that breath over 1 second, and that should take you just a couple of seconds, about 3 seconds. And then once they're intubated and CPR is still going on, you're going to give a breath, one breath every 6 seconds. And so at that time, you want to time your breaths with them coming up. So when they compress down and they're at the bottom, they start coming up, that's when you're. But while they're counting, they might not even be counting at that point because it's continuous cycles. You're still going to be counting 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6. So the way I do it, when I hit 6, I push, I let go, 1, 1,000, 2, 1,000, 3, 1,000. I might go get to 5 and go breathe. And that reminds me to squeeze the bag. Even experienced medics, nurses, doctors, respiratory therapists, in the heat of a moment, will start just squeezing the bag, not thinking about it. And they just get in the moment. I've seen respiratory therapists with 15, 20 years experience sitting there just bagging them like this, not thinking about what they're doing. Say, hey, you might want to slow down. I found myself doing that. So it's, you get caught up in the moment. That's why you want to count out loud, count yourself. Count whenever you squeeze that bag. That'll slow you down.
Kind of what Jim's going off of too. The more you can communicate, the better. Straight up, once the airway's secured and you're bagging them, and you're the person bagging them, I can get boring because you're just sitting here like this and you're just counting and you see all this other stuff going on and all these other things you have to worry about. But this is you, right? Or they have a tube and you're holding the tube, right? And so sometimes you get lost in other stuff and you're not paying attention. Never be afraid to over communicate and tell your partner, hey, Jim, I'm getting good chest rise and fall. And he's like, okay, sounds good. Hey, Stacy, can you listen to breath sounds one more time? Because then things are still happening. Your partner's informed and people get like zoned out up here when you're just sitting here for every 6 seconds, right? So if you want to communicate, talk about it instead of just counting, that's another way too. And then it keeps everyone else informed. I'm one of those people because I sit here and I want to do all the other stuff that's cool and exciting. And I want to go look at the crash scene. But airway is most important, but sometimes it can numb your mind a little bit, to be honest. So communicate, reassess, do all your stuff. All right.
I think a lot of when you look at what's the best way to bag and watching it. So when it, if, depending on who you're with, my partner likes to put that thing on continuous to start with, and you can't give your 2 breaths on it. You can't, it's really hard to, without the tube in, to give a good breath when it comes up. So there's a 30 and 2, and then it's 20 minutes. So it's the same concept when you see that plunger go down and start to come back up.
Oh, Lucas.
Lucas is an automated CPR device. We'll bring one in and let you guys take a look at it. There's the Lucases, there's the Auto Pulse, there's a bunch of them out there. Like the Lucas has got a plunger on it. You put it in the middle of the chest, you hit it, it just starts doing it.
It looks very violent.
It is very violent, very good.
And it saves you some trouble. Also, if your Hamilton T1 ventilators are up to date, they actually have a CPR option, and the machine will sense every time that Lucas lifts and it'll deliver the breath. So if you can connect the Hamilton T1 to a tube and they're getting that, the machine does it for you. If they have it there.
Yeah, we don't.
So, but it is nice. All right. Any questions yet? Any other questions? Okay. Oh, wait, go back. Never mind. I talked about it already. All right. So even though we could be doing the best breaths ever, there's still going to be negative effects on our patient. The worse you do this, the more negative these are going to be. The first one, decreased cardiac output and blood pressure. Whenever you give someone extra pressure through their lungs, based on how that pressure system plays between your lungs and your cardiovascular system, you're going to drop their cardiac output and blood pressure. If you have too much pressure, meaning you have too much PEEP, you're going to tank their cardiac output and their blood pressure. This is more related to things like a BiPAP or a CPAP, because typically you're not going to have super high pressures on this, but that is a consequence of positive pressure ventilation. Another one is that gastric distension. So even if you're doing awesome breaths, the ET tube is perfect, you're still at risk and you're still probably going to get some air into that stomach. And again, when you have too much air in the stomach, it allows less room for that diaphragm to move, meaning that eventually your ventilation is going to go down. So that's why when your paramedic drops an ET tube, if you have a supraglottic airway in place, that's where the NG or OG comes in to go into the stomach, and we help suck additional air and contents out of there. This is especially pushed in peds patients because of how their anatomy is and how much smaller they are. You have less room for error. And then the last one is hyperinflation, especially if you're not doing it correctly. You can actually cause the lungs to hyperinflate, so there's all this air trapping inside of it. So then you can keep pushing air in, but if not all of it's coming out, you're just kind of slowly building them up like a balloon. The hyperinflation is especially important in asthmatic patients where they can't get the expiratory phase as well. I've had patients that have asthma that you could do awesome bagging and they're still going to get hyperinflated. You stop bagging, you disconnect them from this, and you literally just push on their chest. And you allow all that air to come out, and then you restart. But those are all things that can happen with positive pressure ventilation and with bagging someone. So the better you bag them, the least likely all of these are going to be. Any questions on that? All right. Our last big section, we talk a lot about ventilation, and we talk a lot about hypoxia and breathing, and what is really the difference? When we talk about ventilation, it really is simply respiration. Are we having enough pressure to push air in and out? Are they getting enough air in? Are they able to get enough air out? It focuses more on the breathing part. When we talk about oxygenation, we're talking about if they have enough oxygen. You could give someone all the oxygen in the world, but if they don't have enough pressure, and then if they don't have enough inhalation and exhalation at correct times, all that oxygen isn't going to be allowed to go in for gas exchange. So when we think oxygenation, we're thinking a lot about hypoxia. We're thinking about how much oxygen we're giving them in terms of what device, and then how much PEEP we're giving them. So when we look at oxygenation, we're looking at PEEP, and we're looking at FiO2, or the amount of oxygen we're giving them. So when we went back to that table, it was the 44% for a nasal cannula, 80% for a mask, or whatever it was. But that's when we're thinking oxygenation. So if we feel like we're not able to give them enough oxygen, are we using the right device? Are we using the right flow rate? How is their cardiovascular status? Someone with heart failure or morbid obesity, diabetes, all these other conditions where it causes pooling of blood in their legs, that's a stagnant hypoxia. That blood's not able to move. Is there bleeding? Have we controlled the bleeding? Are they continually bleeding somewhere? So are they anemic and that's why we're not able to oxygenate them? Do they have some kind of poisoning? Remember in carbon monoxide poisoning, carbon monoxide attaches to the hemoglobin instead of oxygen because it has a higher affinity for it. And then emphysema, PE, stroke, MI, those can all cause problems with oxygenation. So are they really hypoxic? Their oxygen is low. When we think of ventilation, we're going to think overall breathing and respiration. Are we giving them enough volume? Are we seeing chest rise and fall? Is chest rise and fall equal? How fast are we giving it? What is the rate? And then even though PEEP ties mainly into oxygen, especially when we talk vent theory, do they need a little bit of PEEP to recruit it? Can you click on that, Jim? So this is going to be a video of the differences in PEEP when they first start. This is a cadaver, so this is a real person. It's not bloody or anything, but when they first when they first start back. Oh wait, go backwards, Jim. Don't show them the good stuff yet. What are you doing? I'm a woman. I can't wait.
You go.
Okay, so when they first start bagging, minimal PEEP, right? Now they're gonna add some PEEP. Look at how much more inflation you get. So not only are they able to deliver a greater volume to that patient to get them to participate in gas exchange, think about all the alveoli that's lining that lung and how much more you were able to increase it. But that's the power of PEEP. Especially in kids. Kids will need higher pressures at times. So that's where you might turn your PEEP up a little. But if that's still unfamiliar, not as common to you, please ask your partner, do you want me to increase PEEP? But that's kind of the difference. And then we're good partners. So even though you guys can't intubate in the state of Wyoming, you can't put supraglottic airways in, there are things you can do to set your partner up for success, like knowing how to put an end tidal on that we went over yesterday. I know something that tripped me up when I first started in trauma. The doctor kept asking for someone named Miller or Mac, and I didn't know the difference. A Mac is curved, like a C. That's how I remembered. And then one of my preceptors in the ER here was like, I'm Jesse Miller and I'm straight. So that's how I remember that now. But if your partner's like, Jim's like, hey, I need a 3 Mac, you just look at the size and you know Mac is curved, like C. And that's the different types of gyroscopes. But knowing how to help with other procedures is extremely important because then you might have the patient where you're inserting that 14 gauge needle, your paramedic's inserting a 14 gauge needle into a 5-year-old on the side of a road, and that's your airway. And you literally connect a 3 to 5 mil syringe to this needle, and then you bag him through that. Those are the kind of things that Jim might have to do if you're his partner. It's called a needle crike. It's for younger kids. But they literally stick a needle in there, and then they put a syringe on it, and then they put the end of a breathing tube, just the little plastic part, and you literally bag through that. Typically, if something like that's happened, your paramedic's going to own that airway because that little plastic part for the needle is what your airway is for that child. So the more you can focus, the more you can cognitively offload, the more you understand what your partner may be doing, the more you can help the team, the patient, the transfer of care. So these things are wild, and I have seen them. So be a good partner. Know what's up. Because again, there's a lot of things out of your scope of practice, but you might see it and you might need help with it.
What would cause you to have to do that instead of putting in a?
If they have some kind of obstruction or severe facial trauma. Yep. So if they can't get a tube for some other reason, typically it's like 3 times and you're done trying to intubate. They'll do that. If they're obstructed, like say they had an anaphylactic reaction, you're not going to be able to pass a tube through that. If they swallowed a penny and you can't push that penny down or pick it up, whenever you can't do that, you go here. It's not great. So focus. You guys have any questions? Okay, so I know we have some time, obviously, for class left. We got like an hour. I'm sure we're going to practice all these things. I do have a quick case study. Did you guys want to go through the quick case study? It is very like informal. You can throw whatever you want out there. I don't care if you joke, but we can do that next if you wanted. Okay, do you guys want to take a break first? Okay, break. Did I email you that?
I don't know.
All right, guys. So this is a very informal case study. I did not base it off of anything other than a similar patient that I've had. It's very like open to interpretation, supposed to get you in like the mindset of how you might handle a call, the things you might see, the way that you're going to be able to take chapter 9 and 10 and break it down into what's actually been seen in the field. So these are more like tips and tricks, tying in knowledge, because again, there's that critical thinking, that critical application of being able to say low oxygen is 90%, less than 90%. My patient's at 78%. I know that's low. What am I going to do about it? And then if they don't get better with each intervention, what am I going to do? What am I reassessing? But since we have a little extra time, maybe this might help some of you, and then we'll just practice. Does that sound okay? Great. All right, so you arrived to work at 6 a.m. What are some rig check considerations in terms of equipment in general, oxygen that you're thinking about when you are thinking about checking a rig check when you first get to work? Yep, do you have a full tank of oxygen? Yep, all the tubing. Yep, all your masks. Is your suction prepared? Yep, medications. Is it clean? Yep, PPE. Sometimes too, asking the crew that just came off, like if we're switching, hey Jim, did you have any patients? Yeah, I had a fully intubate, this little 78-year-old. We coded her for 2 hours and then we called it. So it gets you thinking, okay, I really need to check my airway stuff or medications, make sure the Lucas is charged. So sometimes knowing what the crew before you did will help cue you in on what to focus, especially on for your shift. Those are all good things. Is there gas in the truck? Is the oxygen on or off? Warming measures, fluids. Okay, diesels. Told you, I'm just a nurse. Let's also think about how do you prepare for your day. So a lot of times in the classroom, it's like you make coffee, you got your little snacky snacks, you got all your like 7 different colored pens, but it's like, what do you like to carry on you? When do you like to eat breakfast? When do you like to have your coffee? Which obviously you could be running around all day. You could get that call where it's like, hey, you want to come in early for this Denver run? So once you get into a better groove too, the more you can prepare yourself for a little bit smoother of a day, the better as well. And then attitude and mindset is huge. This job and people and patients and partners can suck the life out of you. And it's horrible. And you go home tired. And then it's like, also, I just have this belief that a lot of first responders and healthcare professionals get left in the dust. Like, we take care of patients all day, and then because we're like the best helpers ever, we help everyone at home. But then you sit there and you're like, who's helping me? And you're like, it's not even me. So, whatever you need to do to start your day, to get ready for it, even if you have to gaslight yourself that it's going to be like the best day ever because you're with Timmy, and Timmy is the worst partner ever, do what you got to do. But it'll make the day better. Make sense? Again, I told you this is informal. It just helps with the mindset.
Those are the only 2 things you fully have control of.
Yes.
Everything else you don't.
And the more you prepare your mind for positivity, I think the less likely you are going to freeze. If you're like, I did my skills, I passed my tests, I did my rig checks, I know everything's on there. Stay positive. When you get to that patient that's horrible, you're like, I have all the things I need. It's gonna be an okay day. And also, oh, Jim, what are you doing? And also, your energy affects everyone else around you. So, when you're sitting there and you're like, place, your partner's gonna be like, yeah, fuck this place. But if you're like, we're gonna have the best day ever, energy is contagious. All right, so the scenario. I don't remember how Douglas does their stuff. Your book's all intense about the calls. Casper is like dead. 1900 First Street or something. I don't know. But you got your pager or whatever. And all you get is car crash, NBC versus deer, patient ejected, unresponsive, not breathing on side of the road. And you have 20 minutes out. And it's you and your partner, and you only are BLS providers. What are you guys thinking?
I'm thinking,
Yeah. Yep. So that is awesome. Life flight, who are we going to call? Because if this patient needs ACLS, they need higher level of care and things done in the field, it's important to know who your backup is. Even if it's just, hey, can you make sure fire's coming? We may need extra hands. Because then that patient may be 450 pounds. Me and Stacy ain't lifting 450 pounds. Not the thing. Yeah. I ain't hurt my back over that. Sorry. Also, you got 20 minutes. That is 20 minutes of talking to your partner. Hey, Stacy, do you want to take lead? Do you want me to take lead? Okay, I'll take lead. If you want to get him on the monitor, I'll do the ABCs. Stacy's like, okay. So you understand the expectations of when you're getting to the scene, what to expect from yourself, what to expect from your partner. Brainstorming is huge, I think, especially on your way to something that this is what you get, and that's all it is. So the more you can brainstorm, the more you can maybe prepare is awesome. And then think about it. Say, okay, Stacy, if he gets there, I'm gonna assess the ABCs, I'm gonna get him positioned, I'm gonna think about a C collar, and then we got OPAs, MPAs, and we can bag him. Like, think about those things. Think how you want to play. Practice like you want to play. So that's 20 minutes to talk about things, especially when you're new. Eventually, if Stacy and I are partners for years and years, we just kind of do it. You just kind of do your stuff. Your partner and you fill your roles, but when you're new, that's a great opportunity too. Say, hey, Jim, what are you thinking about for this? And you're just doing your little ride-alongs. So pregame, it's important. Anything else you guys are thinking? Maybe like, oh shit, what the hell? Why is this my first call out of school? Yeah? Okay. No, it's almost 9 o'clock. I'm fading too, guys. Okay, we talked about it. I don't even know what I wrote on these things. All right, you get to the scene, and the scene is safe. Step 0 is done. The deer is dead. You're on a side road near town. You got 2 sheriff's vehicles. They arrive right behind you, and they're just helping to manage traffic.
Law enforcement does one half,
No,
except for Rudy.
Rudy's nice. So don't expect just because they're there that they're going to help. I'm not putting sheriff's office down. They're just an example that I use for the scenario. All right, you can go to the next one. All right, your patient care begins. So your scene is safe. You know you're not going to get run over. It's not Pet Cemetery. The deer is dead. No, you're not going to take it home because it looks disgusting. What is your primary assessment about in general? Yep. P has pulsatile blood coming out of his leg. What are you going to do first? You're going to put a tourniquet on. He's a trauma patient. CABC. Primary assessment, you're going to rule out life-threatening emergencies. It's not throwing them on the machine at that point. You might say, hey, Stacy, hold pressure. I'm going to put this tourniquet on. Primary assessment is life-threatening emergencies. CABC. You're very limited in your primary stuff. There's a lot of other emergencies, but not really interventions you can do. So that's why we don't talk about primary assessment as much. When we look at secondary assessment and vital signs, we've controlled his bleeding. What are we going to do next? Sorry, let me rewind this. I forgot I had him unconscious. You control the bleeding. What are you going to do next? Yep. So he's got a pulse, but he's still unconscious. His head's kind of tilted down. He's snoring a little bit. What are you going to do? Yep. We're going to jaw thrust his head for his airway.
Just getting a little ahead of time, but if their head's cocked to the side and they're snoring respirations, you want to manually bring it back in line. That's going to open their airway up. No, you're gonna, in order to put that neck brace on, you gotta manually bring that back into where it is. You're gonna do it carefully. I mean, if you start moving it, you feel it lock out, you're not gonna move it any further. You're gonna hold it. That neck brace is not gonna go on. The collar won't go on at that point. You're gonna be holding that head there. You can cushion around it, do stuff with it to stabilize it in that position without putting the seatbelt on. And we'll get into that later, but you want to bring that manually back in line where it's supposed to be. And you're not just going to go up and it's going to be a nice slow movement into position, get it into where you can open the airway with the jaw thrust and make sure it's in line with where it needs to be. That might be all you have to do. And he might start breathing on his own. Amazing. And we come up, snoring respirations like this, bring them back, they're breathing fine. And just that little bit of movement isn't going to finish them off unless you.
Yep.
Yeah. Nothing moves.
Just like you guys did yesterday. Thank you for being gentle to my face. But you all just you went in there so like quick though. There was no hesitation, which was awesome. But everyone was very gentle. You just open my airway, that's all you gotta do. And that is honestly the pace you need to do. So it was great. I'm not trying to make fun of you. That was just so awesome. Usually people are like, oh god, I want to touch my instructor. And you were just like, fuck it. And did it. But if you guys ever have to choose between C-spine and airway, you will always choose airway. Because if you can't have them breathe, you have nothing else. So say that, okay, so you position his airway, you jaw thrust him because you're awesome providers and know he's a trauma patient. You're not going to hyperextend the neck and prevent and make further problems. You've put a C-collar on him just in case as well, real quick. He's breathing okay. What are we looking at for secondary assessment and vital signs? So we've saved his life for now. We've stopped life-threatening emergencies. What are we going to look next? Yep. So it was basically your full head to toe assessment.
You know, we talked about doing a rapid trauma assessment. So you start at the head, you work your way down, looking for anything you might have missed on that primary assessment. They had something obviously squirting out, say his femur. was squirting blood out, the tourniquet on in. Well, you missing? You know, got the airway secured, circulation taken care of, breathing all right, and go head to toe to make sure that there's nothing else.
Yep.
You didn't miss the fence post sticking out of his chest.
That's where you can get them trauma naked too. So start cutting clothes, as long as it's not too cold. Look at their pupils real quick. You can kind of feel, palpate as you go down. Listen to the lungs, heart. Check pulses everywhere. Check pelvis again. Look at their legs. And then what vital signs do you think you want from this guy? What's everything you're going to put on him? Yep. 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 Mm-hmm. Cap refill is kind of with your secondary assessment. If he was unconscious before or not breathing super well, you could always, pulse ox, you could throw him on an end tidal. How often do you think you should be getting blood pressures on him? Yep, every 5 minutes. So say his oxygen's 82% and your jaw thrusting in, and his lung sounds are all diminished. What are you gonna do? Yep, so we're gonna put him on oxygen. What device do you want to put him on? Okay, no facial trauma. That's good. So no facial trauma. We want to put him on oxygen because he's 82% with a jaw thrust. What are we gonna put on him? We're gonna put him on a rebreather. We're gonna give him the most to get him up quicker. Yep, so we're gonna throw him on a non-rebreather.
Big nasal cannula. So for the normal patient, we want to give them above 94%. We don't need them at 100%. In between that 90 to 94% and above. Cardiac patients, usually you can give them above 90, we're happy. But trauma patients, we really want to get above that 90. So if they're at 80 for nasal cannula, it's probably not going to get them up. You want to think non-rebreather. Trauma patient probably non-rebreather.
Yep. You want to get him up quicker. Plus, we know he's had pulsatile blood coming out of his leg. So we're thinking blood, we've lost blood. We're not able to move as much oxygen around. We want to kind of load him up too. And then say that he still has an altered mental status. And we decide to go ahead and put in an airway adjunct to try to still get that oxygen up. OPA or NPA, which one are we going to do? Yes. So he does have a gag reflex. What are we going to put in? Yep. How do we put it in NPA? Yep, you're going to lube it up. Are they typically made for left or right nair? Yep. And then you're going to look in there. You just look. Yep, right nair seems good. Which way does the bevel go? Yep, towards the septum. What happens if I meet resistance? Yeah, why? Why can't I just push it in there? So he doesn't have any facial trauma. So we're cleared there. But if you shove it in there, you can cause a bleed, which can also lead to infection because it's cut. And there's the terminates in your nose that help move air and make a certain flow. And then you'll just get stuck on those terminates. It's basically a hard stop. So can I put my mask over my NPA? Yep. And then we didn't talk about this yet, but what if his blood pressure's kind of low? We obviously can't do IVs, right? Can't do fluids. What is a position? What is the shock position you can put him in?
They don't teach trauma.
What? Oh, well, it's head down. To get the blood from their legs to pool or to come down. But that's dumb. All right, so what have we done so far? We put a tourniquet on. We've done our primary, secondary assessments. We've done our vital signs. We put a tourniquet on. We've put in an NPA, and we have them on a non-rebreather mask. What are our reassessments going to look like? Yep. Is our oxygen stats improving? We're going to say they are.
You like on the tourniquet, how long do you leave that on there? Supposed to release it all?
Once it's on, it's different.
If you can note the time, that's extremely helpful when you get to the hospital because certain tourniquets, especially if it's on a leg, are typically 4 to 6 hours. So that way it'll give them a time. If you're like, I put the tourniquet on at 1, you can Sharpie it on there. And some of them actually have a place to write the time on, but you'll leave it. And then if you get somewhere, say a bystander saw it and they belted it, they literally just took their belt off and tied it, and it's not bleeding, you leave the tourniquet on. If the first tourniquet fails, because you always want the tourniquet as close to the bleed as possible, if that one fails, you're going to put a second one on 2 inches above it. So we can also assess not only our NPA, our oxygenation, essentially, airway management, we can also assess our tourniquet to make sure we've stopped the bleeding. We've got our vital signs going every 5 minutes. We're about 20 minutes out from the hospital. I'd say with BLS, you load them up, you crank the heat up. You'll learn more about trauma, but hypothermia is not a good thing for a trauma patient. It can actually lead to them dying quicker. And then I call report. What would you say on report? Yep. So general radio stuff. It's, hey you, this is me. So I know Douglas does calling, but if it was just straight radio, you could say Douglas ER, MS66, and they'd say go MS66. You'd say how far out you are, 20 minutes out, about a 60-year-old male, MVC versus deer, ejected. He was unconscious and unresponsive when we got there. We've put in an NPA. We have him jaw thrusted in a C-collar, 15 liters non-rebreather. We had to apply a tourniquet on his right leg for bleeding. Bleeding is controlled at this time. Here's a set of vital signs. ETA 20 minutes. Questions or concerns? Or you hear questions or orders. A good report goes a long way in transfer of care and how they're going to treat that patient. I'm a stickler for reports. I don't like a bad report. You can still be brief and concise and give a good picture of your patient. And please, if you do good patient care, if you're active in patient care, have some confidence when you're giving a report and just say what you know because you're going to know it. Don't, I think we're 15 minutes out and he's maybe like 57. Yeah, and he had a blue Ford. He was driving and he hit a pretty big deer. It was an 8-point, and don't do that. It's about the patient. Tell him what you know. Give him the good stuff, and then get there.
Your knowledge is the novel of what happened. The only thing you should be given on your radio reports or your calling reports and your handoff reports is the flip notes.
Yep.
So what's important about the novel that they need to know? Okay. And there's nothing wrong with before you call in a report, sitting there and figuring out what you're going to say. I've been doing this for 20 years, over 20 years now. And if it's a bad call, I will take my notebook out and I will write down what I need to give. And especially if we got like 3 or 4 patients that we're dealing with. There's a page for each patient. And you don't want to overload them, so give them about 10 to 20 seconds worth of information, say break, take a second, collect yourself, give them the rest of the information. You don't have to give them everything all at once. We've had stuff change in the middle of a report. And all of a sudden I'd say, I'll tell you about it. I hang up on and start doing what I need to do again, call them back when we do have radio comms now in the ER, so that's nice. But so there's places where we don't have good cell phone service, and there's places where we don't have good radio service, and there's places where we don't have either one. So there's going to be times where you go to give your report, you got it all in your head, and there's nothing on the phone, there's nothing. So now you got to wait until you get that service again. There's other times where you're so busy you don't get a chance to call a reporter, in which case you just have your driver or whoever's got radio comms, if they can, call into the PD and say that we're coming in with this, and it's going to be, we're coming in with an unconscious male CPR. That might be all the thing we get.
Because then when you have hopefully a good ER crew, wherever you may be, if you say cardiac arrest 5 minutes out, they might have a full ER with no bed. And they're going to want to prep all these things, and they're going to move some patients. So as soon as you can, the most concise you can, that's going to help transfer care too. Because we've all been there where we have a really sick patient and we're like, I want to be done with this. You don't want to be having that patient on the call longer than you need. Does that help any? Okay. It's very, again, informal. It's not to paint this huge picture of the patient. It's just, what am I going to do? How am I going to do it? What am I going to reassess? Then what am I going to tell them? That's all I got. We can just practice stuff.
Good. Less than a half hour.
Okay.
We'll just call it a night for tonight. You come back in tomorrow. Randy coming in tomorrow?
Yep.
So